All right. Good morning, everyone. So lots to do today, lots to do. So we are going to play Jeopardy finally from the sex offenders lecture. We've got a lot of people to play. Let's see. We've got Ashley, who's here. Jordan, where's Jordan? I thought I just saw you. There you are, Jordan. Sam, I see Sam. Darren, where's Darren? There's Darren. Josh, I see Josh Williams. The only one I don't see is Robin. Do we have Robin today? I see no Robin. Okay, so the names I just called, let me pull up the lecture and we will get started with some Jeopardy. Okay. Okay, here we go. Let me just resize you guys so I can see some more faces. So I don't have to ask every time somebody answers who that was. All right, so we got Ashley, Sam, Darren, Jordan, and Josh. Okay, we ready? Here we go.
True.
That is correct. All right, next question.
False.
That is correct. I think she beat you to it.
Yeah. She did.
Yeah. Okay, here we go.
Behavioral treatment.
Yeah.
Cognitive treatment.
Cognitive is more common than the behavioral. We don't use behavioral that much anymore. But
I think all the creepy castration stuff too. We gotta mention
yes, that is not the official
not
word
common,
for
but it's
it.
there.
It's I see that you added the creepy part. Chemical castration or hormonal treatment. Yes, those are also, I mean, not super duper common, but it does happen. All right, here we go.
There's like no way out of it. Like once they get in, there's no protections to help them get out of the system.
Yes, that is correct. That is a giant problem. All right.
I recommend that juveniles be considered on a case-by-case basis for the lifetime offender status because there's evidence that supports that they'll age out with the age crime curve.
That is correct. Well, Ashley won by a landslide. The rest of you will get a 5 out of 5 for playing. Do we have any questions about sex offenders before we start talking about the crazies? There we go. All right. So this week, what we are talking about are mentally ill offenders. So we got pretty far through the lecture in the first class, so hopefully we won't have to bring this back up on Monday to like sort of go over that stuff again, or have to send you guys a follow-up video. I'm hoping to be able to finish this whole lecture in just Wednesday and Friday. Quick reminder, your policy briefs are due on Friday. The portal to submit them is already open if you'd like to go ahead and do that. For those of you that are hoping to get an appointment with me, I am fully booked for the rest of the week. The best I can do is if you have very specific questions, I can answer them via email, but I don't edit drafts through email. So if you have a specific question, please email me. I'm happy to answer that for you or to clarify any confusion that you may have. Or if you're still having trouble, deciphering what a limitation is, one of the limitations, or if you just don't understand a finding, I'm happy to help you with that. All right, so let's talk about mentally ill offenders. So data on arrest and incarceration rates have consistently shown that individuals with a psychiatric disability are overrepresented in the criminal justice system compared to the general population. So it's estimated that the jail population has about 2 to 3 times as many individuals with a serious mental illness than the general population. So one acronym that you are going to see this entire lecture is SMI. So I know for you guys that means, it was Saturday or Sunday morning inspection. I think it's Saturday, right? Saturday morning inspection for you guys. That's not what we're talking about here. For our lecture and for our purposes, an SMI is a serious mental illness. So if you see that acronym sort of peppered in throughout this lecture, I am not talking about your inspection. I am talking about a serious mental illness. So what we were saying before, the sort of rant about serious mental illness, it's estimated that the jail population has about 2 to 3 times as many individuals with an SMI or a serious mental illness than the general population. And this rate has been gradually increasing since the early 1980s. So when we dive into the specific prevalence rates, what we see is that jail inmates are more likely to have symptoms of mental illnesses. So when we look at the statistics, about 60% of jail inmates have symptoms of a serious mental illness, followed by the state. We see about 49% of state offenders have symptoms of a mental illness, and about 40% of federal prisoners have symptoms of a mental illness. What we also see is that people that have symptoms of a mental illness, it's pretty common for them to not actually have a history of a mental illness. So when we're talking about a history of a mental illness, I mean that they have been told by a doctor that they do in fact have a mental illness, so they've been officially diagnosed, or they've had an overnight stay in a hospital because of a mental illness. Or perhaps they've used a prescription prescribed by a doctor to counteract the effects of a mental illness, or they've had to have professional mental health therapy. So that's what we mean when we say a history of mental illness. And the majority of the people that have symptoms don't have a history of mental illness. So you can kind of pull from that what you will, but a lot of criminologists have indicated that the extremely stressful situation of being in an incarcerated setting can bring on some symptoms of a mental illness. Or perhaps they just haven't had health insurance and haven't had the wherewithal to go get tested. So when we look at the prevalence rates of people with a history of mental illness in an incarcerated setting, about a quarter of all state inmates have a history of mental illness. About 20% of jail inmates have a history of mental illness, and about 13% of federal inmates have mental illness. But when we're just looking at the symptoms, it's much more common in jails compared to other incarcerated settings.
Could you repeat those percentages again?
Yes, for these, the history or the symptoms or both?
Both, I guess.
Okay, so the symptoms, we see 60% of jail inmates. %49 of state inmates, and 40% of federal prisoners. Now, when we look at the history, we see that 24% of state prisoners have a history of mental illness. 20% of jail inmates have a history of mental illness. And 13% of federal inmates have a history of mental illness. So you can see that huge gap between the symptoms and the actual history of a mental illness. The other thing that's pretty common knowledge is that incarcerated females are much more likely to have higher rates of mental illnesses than males, which should sound familiar. That's one of the things we talked about when we talked about female inmates way back in lecture 4. So we're going to learn a new word today. So the majority of people that have a mental illness are dually diagnosed. So a dual diagnosis means that they have a mental disorder or mental illness and a substance abuse problem. So if you hear the phrase dual diagnosis, that means mental illness and substance abuse. So those are those two diagnoses. There are three ways to say this. Dual diagnosis is one, co-occurring disorder is another, and the third way to say it is comorbidity. All three of those things mean that they have a mental illness and a substance abuse problem. So let me repeat those terms again. There's dual diagnosis, co-occurring disorder, and comorbidity. So if any of you are doing your policy brief on either mental health courts or drug offenders and mentally ill offenders, you have probably come across one of those terms. It is very, very common for someone with a mental disorder to also have a substance abuse problem. So there's a lot of reasons why. I'll just briefly cover a few because I usually get this question in class. So a lot of people that have a mental illness would prefer to self-medicate with illegal substances as opposed to either going to a therapist or psychiatrist and getting medication. Both of those things usually require health insurance or the wherewithal to understand that they might have a mental health issue and need to seek professional help about it. Sometimes people just feel kind of blue or feel like they need to sort of calm themselves down. And it's just a lot easier to get illegal drugs than it is to go through the healthcare system and to access those drugs, especially if you don't have health insurance. So sometimes it's just easier. Sometimes they don't really realize that they have a mental illness, or perhaps they do have a mental illness and they are on antipsychotic drugs. A lot of antipsychotic drugs have very unpleasant side effects. And so sometimes they'll self-medicate to deal with those side effects. So for instance, just a few of them, extreme lethargy is a common side effect for antipsychotic medications, meaning that they can barely get out of the bed in the morning. They're so tired, they have trouble like holding their head up. So sometimes they might do uppers to counteract that side effect. Or perhaps the side effect of this antipsychotic drug is just so uncomfortable that they would rather not be on it. So sometimes two other common side effects of antipsychotic drugs are extreme dry mouth to the point where they can't really talk, or they sound funny when they talk, or like extreme saliva production to where they're like drooling all over the place. So those are just a few examples of some of the unpleasant side effects of antipsychotic drugs. So if they are diagnosed and they are on medication, sometimes they just don't want to be on it because of those side effects. They're uncomfortable and they would rather self-medicate, or they're self-medicating to counteract a side effect, if that makes sense. So those are just a few of the reasons why we see some dual diagnosis here is that a lot of the times they're self-medicating and they develop a substance abuse problem. Like I've had a lot of mentally ill patients tell me, especially those with like mild forms of schizophrenia, that when they smoke weed, it quiets the voices in their head. Or OxyContin is another common one that sometimes quiets the voices in their head as well. And that is much more addictive than marijuana. All right, so let's also talk about their recidivism rates. So data on incarceration rates indicate that individuals with a mental illness often serve more jail and prison time compared to individuals without a mental illness who receive similar convictions. So a lot of times when a judge does have a little bit of discretion, people with a mental illness are given a harsher sentence than somebody that doesn't. And they often don't do their time very well. So state prisoners with mental health problems are twice as likely to be injured in a fight since admission. And jail inmates are about 2 to 3 times more likely to report being physically or sexually assaulted. So they kind of get picked on, or they have trouble communicating and they start fights. So they're more likely to get in a fight or be assaulted while they're incarcerated, which sometimes causes them to sort of lash out and extend their jail time. They have much higher recidivism rates than people without mental illnesses. We see that people with a mental illness have a recidivism rate of about 24% within 12 months and 77% within 36 months. And it takes the general population about 5 years to hit that 77% recidivism rate. So they don't do their time well. They often get longer terms of incarceration and they have higher recidivism rates. So let's talk about a couple of reasons why they might have higher recidivism rates. The first one has to do with homelessness. So state prisoners with mental health problems are twice as likely to have been homeless in the year before their arrest. And if they're homeless before they're arrested, that means they probably don't have anywhere to go when they get released. And we already know that transience and being homeless is a predictor of recidivism. So homelessness might have something to do with their high recidivism rates. Another concern for people with mental illnesses is that they have a different age crime curve. So the average age crime curve is between, like, peak offending is usually between like 15 to 19, and we really start to see that peak around 25, but 15 to 19 is like the peak offending for most people without a mental illness. And the thing that's important about that is that most of those years fall within the juvenile justice system. So if you're doing your peak offending as a juvenile, you're more likely to be punished by the juvenile justice system, which is a lot more rehabilitative than the adult system. So people convicted of murder in the juvenile justice system rarely serve more than 10 years. People convicted of murder in the adult system are either given, 20 to life or the death penalty. People with a mental illness, their age crime curve is shifted closer towards adulthood. So people with mental illnesses, their peak offending years are between the ages of 18 to 20. So that means they're more likely to be dealt with the adult criminal justice system, which is a lot more punitive than the juvenile justice system. So first, the next slide, we're going to talk about why there are so many mentally ill offenders in our nation's prisons and jails. But the rest of the lecture, I'm going to talk about ways to divert people out of the criminal justice system. But first, I want to point out that it's never that black and white, right? So when we start to talk about having all these people with mental illnesses in our prisons and jails, everybody is always like, well, why don't we just divert them out? Well, that is an overly simple solution. The way, we do have mechanisms for diverting them out, but it's a lot more complicated than that. The reality is always that people with mental illnesses, they're at some point going to likely find themselves in a correctional setting. But the other issue is that they don't wear a sign around their neck saying, I have a mental illness. So being able to effectively choose the people that need to be diverted out for their mental illness is a lot harder than it seems. Like I said, they don't wear a sign around their neck. A lot of times they don't want to disclose that they have a mental illness because they've been discriminated against in the past. They don't want to be treated differently, or maybe they don't think they have a mental illness, or they think they have it under control. Or perhaps they're just not being communicative at all, and they may seem stable when they're arrested and booked and may not have some sort of breakdown until much later. So something in their environment might trigger them, or some environmental stressor might cause them to start acting out. So a lot of times they don't want to disclose that they have a mental illness, and when we realize it, it's way too late. So it's useful and it's necessary to create these mechanisms to try to divert them out, but it's not as black and white as just saying, oh, okay, you have a mental illness, so we're going to divert you out. It's a lot more nuanced than that. All right, questions about any of these stats? Please let me know, like Josh did, if you need me to repeat any of them. I'm happy to do that, but I'm never going to ask you numbers on an exam. I'll ask you things like what is the most common, okay? All right, so let's talk about why there are so many people with a mental illness in our nation's prisons and jails. So basically, I'm going to tell you a story about a kid named Ricky Wyatt. So this all started with a civil court case that wound up in the Supreme Court, Wyatt versus Stickney, 1972. This was a class action lawsuit. And if you've never heard that phrase before, that's several people banding together to sue someone over a shared experience or a shared negative experience usually. So Ricky Wyatt was a 15-year-old youth who was committed to an Alabama state psychiatric hospital for ungovernable behavior. And when they got, so it was pretty notorious in all the states in the 70s that their state psychiatric hospitals were underfunded and understaffed. And Alabama was no exception to this. So what was common with these state hospitals, state psychiatric hospitals, is when they had too many people to care for, what they would do is just heavily medicate them to the point where they were kind of in a vegetative state and then just leave them there, because they didn't have the resources to develop an individual treatment plan for every single person. So this is exactly what happened to Ricky Wyatt. He was heavily medicated to prevent him from acting out, but no other treatment plans were enacted. And like I said, the state hospitals at that time were understaffed and little care was provided for the patients. So during this court case, Ricky Wyatt was also explaining that the physical facilities were inadequate. He testified that he was sleeping on wet floors. So they were basically just heavily medicating him and leaving him to sleep on a wet floor. So the goal of this class action lawsuit was to establish a constitutional right to treatment. So if you were voluntarily admitting yourself or being admitted by a family member or a friend to a state psychiatric hospital, you should actually receive treatment for your mental illness. And that's what they were fighting for. So they wanted to set a minimum standard of operations for patients in state psychiatric hospitals. So essentially what these state hospitals were doing was warehousing patients, right? They were just kind of medicating them and just leaving them where they were. They were just warehousing them. And the point of the lawsuit was to say, you can't do that. People have a constitutional right to receive mental health treatment. So, as you can probably imagine, the Supreme Court agreed with Ricky Wyatt and his compatriots, and the federal court decision held that state psychiatric hospitals could not warehouse mentally ill patients without offering some degree of rehabilitation. So, like I mentioned before, it wasn't just Alabama that was doing this. It wasn't just Alabama that was unable to adequately provide treatment. So, when this federal judicial directive came down, that every patient had to have an individualized and appropriate course of treatment, a lot of state hospitals realized they didn't have the resources to do that. So, what happened is what we refer to as deinstitutionalization. So most of these hospitals were at over 100% capacity, but to actually create an individualized treatment plan, sometimes they had to release like so many of their patients so that they were only at like 50, 60, or 70% capacity, right? So they basically just had to release a bunch of patients, hi Garrett, so that they could provide individualized treatment plans for all of the people that they had. So that's what we refer to as deinstitutionalization, that they had to release all of these crazy people into the community so that they had enough resources to provide an individualized treatment plan for the patients that they did have. So what ultimately ended up happening is, let's just use an example. So say one state had 4 mental health hospitals, right? And each of them had to release 50% of their patients to be able to provide care with that judicial directive. So when a state governor saw that they had 4 hospitals operating at 50% capacity, they would close 2 of them to just have 2 hospitals at 100% capacity. So what we saw is that 70% of state and county a decrease of over 70% of state and county psychiatric beds between the years of 1972 and 1990, and about 58 psychiatric hospitals were closed around the nation. That is deinstitutionalization, where they just released all of these people. State hospitals were closing to deal with that budget deficit. So I'm sure you could start to see the problems that this caused. So what their plan was that they were going to provide individualized care for these patients like the Supreme Court said they had to. The rest of the patients that they released, they were expecting them to receive treatment in the community in an outpatient setting. So in a state hospital that's inpatient or residential. So outpatient is like what we just talked about when we talked about drug treatment, where you live at home or you live in the community and you receive treatment. You go to a therapist's office a couple of times a week and receive treatment. So that's what they were expecting to happen. So they were saying, we're going to release you from these horrible state hospitals and into the care of the loving arms of your family and your friends, and you'll just receive treatment in the community. So that seems like a great idea, right? Well, it was a terrible idea. So they seem to kind of overestimate the number of family members that were willing to take care of their family members with serious mental illnesses. I mean, if you think about it, if somebody voluntarily admits their child or sister or brother or parent to a state hospital, they are telling the state hospital, I can't care for this person. This person is beyond my capacity for care, right? So when these people were released, they were kind of overestimating the number of family members that would say, yes, please come home. I'll spend all of my time taking care for this person. So even if this person didn't have a family, they were also maybe hoping that the people with mental illnesses would seek treatment on their own. They were overestimating the number of people that would be willing to do that. So we saw a lot of families either maybe starting to take care of this loved one and weren't capable of doing it. So this person would move out. They wouldn't receive treatment on their own. Like I said, a lot of times what happens with people with serious mental illnesses is either they don't think they need treatment, or what's more common, they'll get on their meds, they'll feel normal, and they will feel like they don't need treatment or meds anymore, so they go off their meds. So we're seeing kind of a lot of overlooked issues here. The number of family members that were going to take care of these people, the number of these people that would actually seek treatment on their own. But the third issue that they were forgetting to take into consideration is what we refer to as kind of the cyclical nature of someone with a serious mental illness. So it's pretty common that they will have to go to a state hospital for a little bit of time to get back on their meds, to get feeling normal. They'll be released into the community. They'll do well for a little bit. They'll go off their meds. They'll need to come back to the hospital and kind of reset. So that's what we see a lot with people with serious mental illnesses, is this kind of cyclical nature of having to cycle in and out of the state mental hospital. So they were kind of overlooking all 3 of those issues. So unfortunately, what was happening was basically they flooded the community with mentally ill patients, which of course led to 2 unintended consequences. One, the rise of the homeless population. If you look at when our nation's homeless population started to increase, it was about the mid-70s, right around this time that this happened. The other issue is that this started to become an issue for the criminal justice system, because if you think about it, if you see someone causing a ruckus, talking to themselves, tearing up a street corner, you're going to call the police. and the police are just going to arrest them for disorderly conduct or, destruction of public property, private property, and take them to jail. So we started to see this shift from the mental health community to the criminal justice system as to having to deal with these people with mental illnesses. So sort of the third issue, or the fourth issue, I guess they overlooked, was the availability of community outpatient treatment. It's never been enough, but it wasn't enough to handle the influx of all of these people. Even if all of the family members were willing to take them and the people were willing to take themselves, there just wasn't enough. So the local community health resources were designed for outpatient treatment of fairly stable individuals with mental illnesses. They were not equipped or prepared for the influx of severely disturbed former inpatients. So it was just a massive mess. So in retrospect, the sort of vision of emptying these asylums and replacing them with the loving care of community-based services is very, very oversimplified and was quite a failure. So this happened in 1972. So we've been dealing with this for over 50 years, or about 50 years. And so the criminal justice system has, like we saw on the last slide, I mean, it's almost overrun with people with mental illnesses. So right now we're in an era of decriminalization. So we are basically, the criminal justice system is attempting to focus more on the treatment aspect instead of the punitive nature. So we're saying it shouldn't be illegal to have a mental illness. These people don't need to be punished. They need treatment for their illness. And it's kind of premised on the idea that gaps in treatment and gaps in taking their meds leads to arrest. So out of concern for the criminalization of mental illness, so making it a crime to have a mental illness, the criminal justice system is attempting to divert them out of the criminal justice system and into treatment wherever possible. So for the rest of our lecture today and probably Friday, we're going to talk about the ways that the criminal justice system is trying to divert people with mental illnesses out of the criminal justice system and into treatment. Or worst case scenario, provide treatment for these people in an incarcerated setting. Does anybody have any questions about deinstitutionalization? All right. So let's talk about mental health courts. This is going to sound very familiar. It's basically the same thing as drug court with a few nuanced differences. So one strategy of diverting people with mental illnesses out of the criminal justice system is to send them to mental health court. So basically, mental health courts, like the drug courts, have become popular for dealing with mentally ill offenders. Just like the drug courts, it was pretty common knowledge that the traditional courts were not effective in dealing with mentally ill offenders. They were part of the population of that revolving door of justice, right? So they would get incarcerated, be released, recidivate, come back. And it's because they weren't receiving their treatment. So what they were hoping to do was to force them into treatment using the judicial power of the courts. So just like the drug courts, the mental health courts' authority stems from linking their clients with the appropriate treatment services. And the central focus of these programs is to offer supervised mental health services instead of prosecuting them. So there's a couple of ways that these people can be diverted. It really depends on the state, the jurisdiction. It can be sort of a pre-adjudication where they will send you to drug court before you stand up and plead guilty, not guilty, no contest. It can be, and in that case, they just will dismiss the charges and they won't move forward with them if you do well. If you fail, then they'll move forward with the charges. Or they make you plead guilty first, so post-adjudication. So you would have to plead guilty. And then if you complete these, the mental health court, then you can get your charges expunged. So it's just like the drug courts. We see some variation in how these are implemented specifically. So here's how this works. You'll get an intake screening to make sure that you're eligible for the mental health court. And if you meet the criteria for having a significant mental health disorder, you can be offered diversion. So that criteria differs widely. It differs by court, it differs by state, it differs by jurisdiction, it differs by judge. They all kind of set up their own standard for what they consider to be a mental health disorder, or more specifically, which mental health disorders they will accept. So, following your diversion to this court, you are referred to mental health facilities for treatment and follow-up planning. And similar to the drug courts, you will meet with your judge, quarterly, monthly, so on and so forth, to check your progress. Some of these courts have phases, just like the drug court. So phase 1 will be extremely restrictive with lots of meetings, curfews, so on and so forth. If you do well, you can graduate up to phase 2. If you do better than that, then phase 3, then you'll eventually be released. So it really just varies, but the sort of setup is almost exactly the same as the drug courts. It's just instead of drug counseling or drug treatment, you're getting mental health treatment. So the first court was established, mental health court was established in 1997. And by 2006, we saw over 100 nationwide. So they're all over the place. We have quite a few of them here in the state, but it varies by jurisdiction. So let's talk about some of their eligibility and exclusion criteria. So this citation down at the bottom, this Drain and Colleagues 2008, they surveyed 196 mental health courts to get sort of the pulse of who they accept and who they don't. They saw about 85% of them, so the large majority will accept all misdemeanor cases. So what we're seeing is like 15% of them only accepted like some misdemeanor cases, but the large majority of them will accept all misdemeanors. And about 74% of them will allow certain felony cases to be seen. So a large majority of them will also accept felonies. Only about 20% will take violent felonies. And only about 1% would hear cases involving significant violence. So if you committed a pretty violent offense, it's unlikely you're going to be eligible for mental health court unless you happen to be in that jurisdiction of 1%. Now, let's talk about the mental illnesses they will accept. So about 43% will accept anyone with a diagnosis that corresponds to their state's definition of a serious mental illness or a persistent mental illness. So each state has their own definition of an SMI or a persistent mental illness. So about half of the mental health courts will accept you if you have a diagnosis that goes with that. What is less common, only about a third of courts will accept you if you have a personality disorder. So that often isn't considered a serious mental illness. But like I said, about a third of the courts will accept you with a personality disorder, and a third of courts will accept you if you're mentally challenged, such as Down syndrome. So those people in like a third of states are eligible for mental health court. Here's where it gets kind of sticky. About 64% of these courts excluded you if they determined that substance abuse was the primary disorder, which is not great since we know that a large percentage of people, almost 75% of people with a mental illness, also have a co-occurring disorder. So the fact that 64% of these courts will exclude you if they think that drug abuse is your primary disorder. So what often happens is they'll screen you and they'll say, "Oh, it looks like you are you have a drug addiction, so we'll send you over to drug court." Well, drug court will also exclude you if you have a mental illness, so they'll send you back to mental health court. So we start to see a lot of these people kind of get caught between the two. All right, questions about mental health court. All right, let's do one more slide and then we'll call it a day. So if you are not diverted out to mental health court, I want to go over what could happen to you if you were booked into a jail with a serious mental illness. So this was a really cool study done in 2007 by Lamb and colleagues. So it was a retrospective study of 104 people with a serious mental illness. So what they did was they tracked down 104 people that they knew that had a serious mental illness that had at one point been booked in the LA County Jail. And then they went back to the LA County Jail and got the records of those 104 people to see what sort of treatment they received. So what they found from this was 78 out of the 104 were diagnosed by the jail as having a serious mental illness. So the jail did pretty well. I will say one thing. We're talking about the Los Angeles County Jail, which is a really, really giant, nice, well-funded jail. You're not going to see this in like Berkeley County. The Alcana Detention Center has a really nice jail too. So this study is actually not very generalizable. So if you are booked in a really nice jail, this is what can happen for you. If you are booked in kind of a podunk jail, this is not going to be your experience. But in very nice, well-funded jails, such as the LA County Jail, they properly diagnosed 78 out of the 104 as having a serious mental illness. And of those 78, 59 of them required inpatient care, and they got it. So on Friday, we'll talk about what the wing for mental illness looks like in the LA County Jail. But just briefly, the 59 that required inpatient care. So if you have a mental illness and you go to jail, if you're stable, you can be in the general population. But if you require more acute care, you'll be in the mental health wing. So the Alcana Detention Center, it's called the Special Management Unit, but most jails will have a wing specifically for people with mental illnesses. So 59 out of the 78 had to be in that wing, and 32 required acute hospitalization, meaning they needed round-the-clock care, and about 44% of them were placed on lockdown. So what we see is 76%, so that's the 59 out of 78, required serious help while they were in the correctional system, and they were able to get it, again, in a very nice jail. So the last thing I just want to go through are kind of the demographics of this sample. Nothing on here should surprise you. So of the 78 that were properly diagnosed, 92% of them had a history of non-adherence to their meds, meaning they went off their meds. Again, this is kind of what most experts agree on. If you go off your meds, that's often when you find yourself afoul of the law. So the fact that these people were booked in the jail and 92% of them had a history of going off their meds should not be surprising. Of these people with serious mental illnesses in the jail, 72% had a history of violent arrests. So this jail might be a good place for them. And then the last two shouldn't surprise you either. 76% of them had a history of substance abuse. Shouldn't be surprising. Co-occurring disorders is very common. And about a third of them were homeless. So again, none of these factors should be surprising. People with mental illnesses that wind up in a jail most commonly have a history of going off their meds. Second most common have a history of substance abuse. Also, some of them have some violent arrests, and also about a third of them are homeless. All right, questions about this? All right, so like I said, we're making good progress. I'm thinking we'll be able to get all the way through this lecture in just 2 days this week. So what we'll do, provided we get all the way through the lecture, we will be taking our next quiz on Friday, and that is when the Jeopardy champions will start to play the other champions. So we'll be in the semifinals round. So I'll go through and kind of do the calculations to figure out how many people need to play, and I'll let you guys know on Friday who will be in the playing in the first round in the semifinals, so that you guys know not to take your quiz. If we do not finish the lecture, then what we'll do is I will open up the quiz to like make it like Tuesday at the latest, so that we'll have time to finish the lecture either on Monday, or give you guys time to, if it's just like a 15-minute run through video that I have to send you, I'll give you guys some time to watch that. But I'm thinking we'll be able to finish this on Friday. All right. Don't forget to turn in your policy brief. It's due on Friday. The portal to submit it is open. If you have specific questions, feel free to email me. If there's nothing else, I'll see you guys on Friday.
Bye, Dr.
See you later.
Hi, I was just wondering if I could schedule like another time to do the policy brief. Can you hear
Grace,
me?
I don't have it anymore. I'm all
Alright.
booked. Do you have a specific
That's all right.
question?
No.
Oh, I think I lost you.